Assalamu alaikum. We'll start our today's session with Dr. Hiba. Your case will be Mrs. Lisa, 55 years, came with complaint of fatigue. Okay, I will start timer, then
Mhm.
start straight
Okay,
away.
I will start as a non-Irish. Okay, yeah. Mhm.
Yes, the timer only will
Okay.
be shared, then we can start.
Mhm.
You can see the timer?
Yes.
Okay, start.
Hi, I'm Dr. Mubarak, one of the exam candidates. May I confirm your name and age, please?
Yes, I am Lisa. I am
Mhm.
55.
Hi, Lisa. Nice to meet you. Ms. Lisa, we are here today to discuss some issues related to your health condition. I will ask you some questions and examine you as well. If you need any questions, you can ask me. I may write some notes. It will be confidential and all my attention will be with you. Is that okay?
Sure, doctor.
Okay. Lisa, what brings you to the clinic today?
Doctor, I always tired. I cannot do anything in
Oh,
my daily activity.
okay. I'm sorry about that. And are you okay now?
Yeah, doctor.
Do you need any help?
When I sit,
Okay.
no, doctor, when I sit down, I feel little
Mm-hmm.
bit better than doing activity.
Okay. So when this started?
Long time, doctor, maybe now almost 8 months. I feel this fatigue.
8 months. So before 8 months, you were completely normal.
Yeah, almost, yes, doctor.
Yeah. Okay. So 8 months, is it start sudden or gradual?
No, it was gradual, doctor.
Okay. And is it all the time or is it on and off?
Uh, on and off, doctor, but no particular time for the fatigue.
Okay. So it's not continuous on and off. And is it a progress?
Yeah, I noticed, doctor, that it worse day after day.
Okay. And anything makes it worse? Have you noticed anything
Yeah,
makes it?
doctor. Yeah,
Mhm.
the activity make I cannot tolerate anything to do at home.
Uh, Okay, so it's getting worse with the activity,
Yes.
and you notice an like variation during the day, like when you
N-
wake movement, you feel fresh and start
No, doctor, it's not
tired.
like that. But no, it's not like that, doctor. I mean that when
Mhm.
I do activity, I feel more tired than when I'm taking rest. But still, the fatigue and the tired all the day.
Okay, although there's no variation during the day.
No,
Okay,
doctor.
and when you take rest, you feel yeah, you feel okay when you okay. Do you have any muscle pain?
No, doctor.
Okay. Any weakness?
No, doctor. But I feel that I cannot do anything. I feel I'm weak.
Yeah, yeah, just it is general tiredness, but you
Yeah.
can, but there, yeah, there is no like weakness in special part of your
Mm,
body. There is no abnormal sensation.
no.
Okay, and is it this? Do you feel the weakness all over? There is no side for more than the other side. Yeah.
On all my body, doctor.
Okay. Do you feel sleepy?
Yes, doctor, I feel sleepy as well, and I lost all interest.
Okay. And do you have any any headache, any blurring of vision?
Yeah, doctor, I felt some headache, doctor.
Okay. And when the headache started?
It's no particular time, doctor.
Okay, so yeah, okay. And is it out of 10, 1 is mild and 10 is severe? How much you give
Yeah, when it comes, doctor, it's severe one.
severe? And is it in all in specific place of your head? Do you feel it more in the where more you feel it?
No,
Jen?
mainly, doctor,
Mhm.
mainly I feel it on exactly when I eat, doctor. I feel this headache more worse.
When you eat,
Yes,
okay. Is it a small food or just when you eat?
when I eat, doctor.
Okay, and is it associated? Yeah, is it all over? All over your head or in a specific part?
Yeah, and specific part, doctor, in my head.
Specific part. Which part? Can you
You
describe?
know the area of the hairline, doctor, at that area, the hairline area.
Okay, the hairline. And do you have any vision problem?
Yeah, doctor, you're right, doctor. A month ago, I lost my vision, doctor, and after that time, I cannot see as before, doctor.
Okay, so you lost. What do you mean lost your vision? Is it one eye or two eyes?
One eye, doctor, it's so blurry now. I can't see clearly by the left eye.
And is it a sudden, loss of vision,
Yeah, it was sudden, doctor. Yeah, it was sudden.
sudden, and you lost all your vision?
Yeah, because
Okay,
I
and
went
this.
late to my GP and he
Okay,
did some examination and he told me, yeah, I cannot see more as before.
okay, and when it's come back, the vision,
No,
how
doctor,
long
I
it
cannot
stays?
see. No, no,
So
I
you
cannot see,
cannot
doctor.
see. Okay, you
Yeah,
still
yeah,
cannot see. This is one back.
yeah.
Okay, and do you have any yeah, so in the hairline, anything for the headache? Do you have any? Is it associated with sneezing or lying down?
No, doctor, no, it's not with the sneezing.
Okay. Do you have any past medical history?
No, doctor, I am not having any past medical history.
Okay. Any surgery before?
No, doctor.
Any medication, chronic use of medication?
I'm t using painkiller, doctor.
Okay. Painkiller for the headache?
Yeah,
Okay. And for any allergy?
no, doctor.
Any over the counter rather than the painkiller?
No, doctor.
Just this. Okay. Any recreational drug abuse? Sorry about
No,
that.
doctor, never.
Okay. Any recent vaccination?
No,
Okay. Do you have any difficulty in swallowing?
no,
There is no. You said there is no abnormal sensations, meaning any blackout or loss of vision, or loss of
no,
consciousness.
no,
Any problem in control of your water work or bowel
no,
work? Okay. Any memory changes?
no, doctor, I'm good. My
Any
memory is
problem
good.
with your, yeah, any problem with your gait or balance?
No, doctor.
Any shortness of breath?
No,
Any awareness of heartbeat?
no,
Any lower limb swelling?
no,
Any weather preference?
no,
Any change in your hands or feet size?
no.
Any joint pain, gritty eyes?
Actually, doctor, I had some problem, and not a pain. I feel
Mhm.
all most of my joints stiff, doctor.
Okay, so your joint is stiff. And uh, since when this?
Since all the same duration, doctor, around 8 months now.
Okay, and do you have any skin rash?
No,
Any skin rash to sun exposed area?
no,
Okay. So this stiffness, you said in all the joints, there's any swelling or hotness?
no, doctor. You didn't get me, doctor. It's just stiffness in my joint. I
Okay,
feel
it's just
some stiffness. Yeah, I cannot move my joint at all.
okay. Sorry about that. And yeah, any change in your bowel work, any tummy pain,
No, doctor.
heartburn,
No,
any change in your water work?
no.
Okay. Any family history of the same illness?
My mother was rheumatoid arthritis disease.
Okay. And any other chronic disease in the family?
No, doctor.
Okay. Any history of travel, recent travel?
No.
Okay. Lisa, what about your period? Is it regular?
I already, I'm done with the project, doctor.
Yeah,
No
okay,
more.
yeah. So it's 55. Yeah. And okay. And do you have any history of clots,
No,
any swelling in your legs?
no,
Okay. Any change in your body temperature?
no,
Any weight loss?
no, doctor.
Any appetite change?
No,
Okay. Any night sweating?
no,
Okay, sorry about this. Are you, do you have any casual relationship?
no,
Any needle sharing or
no, doctor. Never.
tattooing, piercing?
No.
Okay, sorry. What's about, what are you doing for a living, Lisa?
I'm retired, doctor. I was accountant. Now I'm retired.
Okay, and with whom are you living?
With my partner.
Okay, and what's the impact of this problem in your life?
I can't help him, doctor. He need more home service, and I can't help him at home.
Mhm. Okay, I'm sorry, I can understand that. Yeah. So, do you smoke?
No, doctor. I quit already.
Okay. Yeah. So, are you drive?
No, doctor. I don't drive.
Mhm. Okay. So, what's your concern, Lisa?
What I have, doctor, is it serious condition? Is it cancer, doctor?
Yeah, from I appreciate your concern, and from what you're saying, I don't think it's a cancer, but we need to do some investigations to look what's
Oh,
the problem. Okay, sorry, can I ask you, do you have any stress in the family or
no, doctor. I don't have any stress at home or with my family.
okay, and your mood is okay?
No, doctor. I lost the interest.
Okay,
I'm
yeah.
not feeling
So
okay.
do you feel the life is precious?
No, no more, doctor. I don't feel that
Okay, do
because
you
of
think
this
to
tiredness.
okay, do you think that you want to end your life?
No, doctor, not to that extent, but I'm not
Mhm.
feeling well, doctor. Help me.
Okay. Yeah. Okay. I'm sorry about that. And just can I will do some examinations and I will
Yeah, sure.
just answer your concern. Okay. So we'll start with the vital blood pressure, temperature, and
Normal, normal.
pulse normal.
Mm.
I will do general examination, looking for any pallor, any jaundice,
No, no
raised
valor, no
GBP.
values.
lower limb edema?
No edema.
Okay, I will do neurological examination for visual acuity and visual field and ophthalmoplegia.
Yeah, in the right, in left eye, she can only see your fingers, but she cannot count movement, only hand movement.
Okay, hand movements, and maybe offer the fundoscope, but
No need.
okay. So other neurological examination, I will do upper limb and lower limb for power
Tone
and
and power and
tone power
reflexes.
reflexes. Mhm.
Yeah, are okay. She can move with the resistance,
Normal.
but
Okay.
yeah,
Mhm.
but she feels some pain in the shoulder.
Pain in the shoulder. Okay.
Yes,
In the the right shoulder or
both sides.
both sides? Okay. And any redness or hotness, restriction of movement?
No, doctor, but she can't move it due to some stiffness in the shoulder.
Okay. Stiffness in the shoulder. Okay. For lower limb is normal. Cranial nerves.
Normal, apart from pelvic, also some stiffness in the pelvis. She cannot move the pelvic girdle.
Okay. Okay. I will do like the head heel test. Look for kyphoscoliosis and head heel test. Is it normal? Any
Normal,
kyphosis?
normal.
Okay.
But
I'll
when you
ask.
ask her to stand up from the chair, she's not able to do it.
Okay, she's not able to stand up from the.
Yeah, from the chair.
Okay. Uh, yeah, and the sensation normal.
All sensation modality normal.
All sensation modality normal. Okay, and what cranial nerves?
And no need.
Yeah, no deformity in the hands, no swelling for
No,
no.
no.
I'll check for the maybe cardiovascular. I'll check if there's any murmur.
Skip, skip.
Okay, pulmonary maybe low zone crepitation.
No, 1 minute remaining.
Upper okay, upper zone crepitation.
No, nothing in the chest.
Nothing. Yeah.
Yeah,
Okay. And abdomen, no organomegaly and
no. Skip. Examiner
no pain.
ask you to skip and
Okay.
is reminding you 30 seconds remaining.
Okay. Yeah. So uh, the gait, she cannot walk. Okay.
Yeah, there is some stiffness while standing, so the examiner told you let her sit and rest.
Okay. Uh,
So answer the concern, doctor, please.
yeah. Concern. It's either looking for multiple sclerosis or uh, functional disorder,
Okay,
fibromyalgia.
so okay, great. Thank you.
Mhm.
Let's now 18 minutes. Let's reset for the examiner question. Try to
Mhm.
collect your thoughts while presenting the patient, and you might reach. Okay.
Okay.
Please present your case.
Okay, so the patient is 55 years old, presented with fatigue, 8 months, which is gradual, on and off, and increase with activity. It's increased with headache, with associated with eating, and it's in the hairline. and she has a loss of vision of one eye since 1 month. It's sudden. No past medical history or surgical. She has joint stiffness from 8 months. She has family history of rheumatoid arthritis. She has depression, and the signs of depression and loss of interest. On the examination, she has decreased visual acuity and in the left eye, and has stiffness in the shoulders and in the back, lower back.
Pelvic girdle.
And
The pelvic girdle. The pelvic girdle, not
yeah.
the back. Okay. So, yeah, collecting this information and data, what do you think about your differential diagnosis?
The only thing that's the loss of vision. Otherwise, I will say it's fibromyalgia.
Okay, fibromyalgia accepted. Yes, great. What else?
Maybe
Similar to fibromyalgia. Give me similar, but it's not like
yeah.
yeah.
I forget the name. Yeah.
What's
Syndrome.
chronic?
Syndrome.
Yeah,
Chronic fatigue syndrome. Chronic fatigue
Yes,
syndrome. Yeah.
excellent.
Chronic fatigue
Okay,
syndrome.
and our case, our case here.
Our case is chronic fatigue syndrome.
No, our case another diagnosis, but I'm trying to trying to
another
take it
diagnosis.
from your okay. Give me another. What else you think about?
Maybe maybe hypokalemia.
But
Periodic.
it's in relation to the food. It's not. So it's not.
Yeah.
Okay. The headache and the blaring and loss of vision.
Yeah, maybe
related to this case.
and 55, maybe temporal arthritis.
Okay. Excellent.
Yeah.
Okay. So what's the case now? Okay, great.
Temporal arthritis. Yeah.
So the association.
Yeah.
What association with?
What association between temporal arthritis and depression? Temporal arthritis causes depression. Depression leads to the
okay. What the association with temporal arthritis as a disease? Okay, let's do the investigation and the approach. Leave the diagnosis now. Okay.
Okay. The investigation. The basic investigation: CBC,
Excellent.
implant
Okay.
marker,
Okay.
RFT, LFT. I will do maybe I didn't do the fatigability test. I should do this in the the examination.
It's okay.
What else? Creatine kinase.
Okay, excellent. What else?
What else? Okay, CBC-ASR for the vasculitis.
Excellent. Excellent. Okay, ASR expecting to be in this patient?
Very high. Yeah.
Yes. Okay.
Very
What
high,
else?
Yeah.
If you suspect.
Temporal biopsy.
Excellent. This is the diagnostic. Yeah. Okay. Diagnostic for temporal arthritis. Okay. And the headache which she has, what's called?
The headache.
The same name of temporal arthritis. It's okay. Okay. Leave it. Okay. How to manage this patient?
Steroids.
Excellent.
Okay, multidisciplinary team. Okay, well, let me start. Multidisciplinary team will start with patient education and counseling about her condition, and will be a multidisciplinary team from rheumatologist, neurologist, maybe immunologists. It could be not occupational, social worker, maybe physiotherapy, and psychology.
Okay.
psychologist.
And
The
the
drug, of course,
pharmacological?
drug of choice is
Yeah,
pharmacological is steroid
excellent.
in
How does
acute, yeah,
yeah, how
high
the
dose
dose?
steroid. I think in acute high dose steroid. My God,
Okay. Do you think this patient is
16.
acute?
No, no, she's not acute now because
Yeah.
no.
So what do you think? So low dose steroids?
Uh, yeah,
Yeah.
low dose steroid.
Okay.
Yeah.
Yes. Okay. Time is up. 6 minutes now. I
Mm-hmm.
will reset. Then I will give you the comment. Yeah, Dr. Tanya wrote for you. She give you the case now. Okay. So what you have here, collecting the ideas and the data in this patient, stiffness. I am insisting this is a stiffness,
Yeah.
doctor. My joints are stiff.
Mm-hmm.
What's the target disease of stiffness of the shoulder and pelvic girdle? What do you think? You will never forget it.
The target.
Yeah, I mean specific or pathognomonic for the stiffness of the joint of the shoulder. Okay, so they are trying to help you in the chat box. They wrote for you the diagnosis. Try to take it, yeah, in order not to
Okay.
forget it again. You saw
Okay.
it
Where? No.
in the chat box.
Can you repeat, please?
What we can
Okay.
do more than this? Okay,
Okay. Uh,
again they are
pain.
writing. Okay,
Yeah. Pain. Polymyalgia rheumatic.
yeah,
Oh, yeah.
yeah.
Yes.
What happened to you, Dr.
Do you know,
Heba?
I remember the picture of that because I'm drawing it
Yeah,
and I'm dealing a lady, a old lady with this temporal arthritis, polymyalgia rheumatic.
yeah.
Yeah.
Yes, I'm telling the association. The association. Okay,
Yes.
so
Yes.
and 50s female
Yeah.
coming with
Yeah.
the long duration. Yeah, I think if the case come to you again, you will know it. But
Yeah.
maybe
Yeah.
you are
Yeah.
mentally blocked. So I
Yes.
will just give you a comment, okay?
Yeah. I thought
Actually,
about this when you said this vision problem and headache and trying
yes,
to
yeah,
just find
exactly.
the place of headache and 55. Yeah, because this is
Yeah,
the age of,
the
yeah.
yeah.
Mhm.
So I will start from the onset course duration. You covered all this data very well. The meaning of fatigue better if you ask me what you mean by fatigue, feel tired. But you ask me by analysis more when you feel and what exactly, what worse, what improve. Yes,
Mhm.
you ask all this. This the headache. You ask me the specific area of the headache, and I
Mhm.
try to point to you the area of my scalp, but I can't tell you scalp. You should ask
Mhm.
myself or you examine at the examination. It's okay.
Yeah.
It will teach you this case and you will
Yes.
never forget PMR. Okay.
Yeah.
The scale of the headache you gave to me, the association as vision. Yeah, I give you
Mhm.
sudden loss vision. It was painful if you ask me. And
Yeah. Painful. Yeah.
yeah,
Mhm.
yes. And memory, you ask balance. You cover all the CNS very well. Chest, you cover the chest, you ask for the cardiovascular, you ask for, I like your organization today, you too much organized. The weather, the endocrine. When you reach to the joint, I tried to show you the joint affected uh, stiffness and
Mhm. Yeah.
it's worse. Yeah, it's not related to, but when the effort there, the worse, the stiffness more worse. And when I get
Mhm.
rest, my joint being more stiff. So it's
Mhm.
all over the day. Okay,
Yeah.
GI,
Yeah.
genitourinary, female history, the family, the travel, the medical, the surgical, allergy, HIV. You did all the history great and perfect. The constitutional, you ask the mood, job,
Mhm.
and smoking, alcohol, drinking. You did everything.
Mhm.
Apart from reaching diagnosis, even you reach
Yes.
to the yeah temporal arthritis. So it's
Yes.
association. When you reach to temporal arthritis,
Temporary
direct think
arthritis. Yeah.
about PMR, polymyalgia rheumatica.
Mhm.
Okay,
Yeah.
so
I
I
lost
will
the
consider you
name.
pass
Just I'm
this
trying
case.
to. Yeah.
Yeah,
I'm just trying to remember the name. It's in the top of the page. That's in my hair
yeah,
in my
it's okay, it's okay,
head.
and
But
it will
yeah.
never, it will never
Yeah.
be
I will
mistaken
never.
again.
Yeah. Yeah. Of
Mistaken,
course.
yeah.
Yeah.
Yeah, I agree, and I am totally sure that you will never forget it. The
Yes.
differential, you give very nice differential,
Yeah.
fibromyalgia, chronic fatigue syndrome, and
Mm-hmm.
our case here, polymyalgia rheumatica. So I try to make a common case today for all
Yeah.
candidates who's
Mm-hmm.
going near exam. I hope they are joining us.
Yeah.
And for
Okay.
us to
Thank you.
remind,
Yeah.
yeah, thank
Mm-hmm.
you too, Dr. Hiba. You did great, really. I like your organized review today for everything, for the system,
Thank you.
for the social, for the occupational, everything you
But I
covered
didn't
well.
reach the diagnosis.
No, it's
It's
okay.
okay.
If I am examiner, I will give you the full mark, really. Even by
Okay.
your differential, you give me yeah, logic differential. Yes, great. Yes, Dr.
Mm-hmm.
Tanya, clap hand for you. Any
Thank
question
you.
or any comment? Yeah, thank you. Thank you, Dr. Hima. We can receive the comments or question. Well done. Yes. Aluta continue. I don't know what the meaning of aluta continue. Continua. Polymyalgia rheumatica. Dr. Hinaida laughing. Pain, stiffness, polymyalgia rheumatica. Okay, any comment? When would session start? Dr. Tahir, we are starting at 10:30 PSA. In fatigue, important to ask what you mean exactly by fatigue. Yes, Dr. Ruda.
Mm-hmm. Mm-hmm.
Timing, three, affection in daily life and work or weight changes. This is numbers. What you mean exactly by fatigue? Two, timing. Three, affection on daily life. Three,
Mm-hmm.
yeah, and work. And four, weight change. Yes.
Yeah.
Actually, it might be associated, yes, with my loss of weight, but
Mm-hmm.
it's not like cancer.
Yeah. Sometimes yes,
Yeah, not
yeah.
significant. Yeah, there is
Mm-hmm.
sometimes loss of appetite and loss of weight. Yes, I
Yes.
agree.
Mm-hmm.
Okay, any question or any comment from other colleagues?
Yes, Mr.
Okay.
Basim, Salam alaikum.
Yes, alaikum assalam wa rahmatullahi wa
Salam.
barakatuh. Again,
I
Dr.
have a
Mahmoud, yes.
question
Yeah.
uh, in presentation with fatigue because of this many diseases can cause fatigue. My question, I want to know approach that for this fatigue to narrowing differential diagnosis
So
from start.
yeah, you will give me by the analysis. How do you think about fatigue? You think by yourself. What you think if the fatigue is there? How you could ask about and you can reach to the diagnosis. I mean, by the onset course duration, you can even have some clues by this three onset course duration. For example, myasthenia gravis, it will be in the onset course the duration, yes. It will be diurnal variation. But this is one of the differential, and that's why Dr. Rahiba also did fatigability test.
Mm-hmm.
Uh, all over the day, it will guide you either to some either serious disease, or autoimmune connective tissue disease, or cancer or an infection. So fatigue or sometimes anemia, of course, anemia will also cause
Mm-hmm.
fatigue all the day. By taking more history, you can analyze well and you can reach to the diagnosis. For example, in this patient, you will have the association, the headache and the blurring of vision. Okay, in another case, cancer, if you ask for constitutional symptoms, early you can reach the diagnosis if the cancer is the case. The anemia, you can also, by asking cardiovascular system, and you will have racing of the heart, pallor, and if the kidney, sorry, the liver affected, you will have jaundice. So it start your system review calm, and you can reach the diagnosis by asking about the course duration, then constitutional and system review. You will have a clue in the system review, definitely. In such case, you saw the headache and the blurring of vision was the association for polymyalgia rheumatica. At the end, the summary of this fatigue, yes, it's common presentation scenario. Even MS can be there, but you will find the association of MS. So you have a lot of differential, but the case will guide you
Mm-hmm.
which system is affected and which association is there. I hope you got it.
Yes, thank you. This means
Yeah.
the onset of fatigue
Yeah,
والقلق
long term, of course, also different, but the fatigue means long term. It's not acute.
مم.
Yeah, what else you want to add, or what else you want to ask?
Thank you.
Yeah, start onset, course, duration for any complaint in the exam. Then after that, what increase, what decrease, what improve, what worse, and if long or old patient, you can ask for the long-lasting disease, chronic hypertension, chronic if the patient is old. If the patient is young and you suspect something serious, you can start by constitutional symptoms: loss of weight, loss of appetite, lumps and bumps, and the temperature and night sweats. If the patient is young and no seriousness or no serious disease, you can go system review and try to catch what might be the system affected related to the main complaint. This is not only for fatigue. You can follow this system review and what I advise for any complaint. It will guide you to the diagnosis, or at least the differential, which include your diagnosis. Be systematic and you will reach to the diagnosis. Okay?
And what about the examination?
Yeah, you did it well. You did great. You start by the journal look, the vitals, the hand. You mean the case or for your performance?
No, for the case.
Yes, only stiffness and difficult of standing, difficult to move in the passive and in the active.
Yeah.
And
And
the
drop
yeah,
claudication, I think.
yes, this is very important. I told
So,
you the headache worse with the headache with the
yeah,
eating.
with eating. Yeah.
Yeah, and also it was a clue for you, but I think you didn't catch
Yeah.
it. It's
Yeah.
okay.
So this is, yeah.
Yeah,
It's just like it goes in front of my eyes. Yeah. It's then I missed.
yeah,
I don't know.
it's okay.
Yeah.
Okay, the scalp you can ask, but before asking, offer if she has pain or not. Because if she
Yeah.
out, yeah, you will also out. The eye, as you did, a visual, starting by the acuity. Patient already lost her vision, so
Yeah.
acuity will be
The
affected.
acuity. Yeah.
Yeah, and the other things is not affected. I mean, the field, no affection to the field, and reflexes not affected. That's it. The fundoscopy, I'm not sure about optic atrophy because it's arthritis of the ophthalmic, I think, or I'm not sure. So I will not say more details about fundoscopy. If someone is sure, if you can share with us. If Dr. Rabia also here, Dr. Rabia, our neurologist.
Okay.
Dr.
You
Dalia is
can.
raising her hand.
Hello,
Yes, Dr.
everyone.
Dalia. Yeah,
Yes,
hello.
I raised my hand because one of the colleagues asked about approach. I guess
Yes.
I
Yeah, we
understand
can help.
he wants a map. Okay,
Okay. Yes,
so
draw it.
so okay. First, with fatigue, you need to know is it a real fatigue or something he didn't mean it? Because one of the exam, the complaint outside was fatigue, and when the patient when the candidate enter the station, they found that he means by fatigue it's weakness. So it is totally changed to neurology. Okay, so you need first question to know what do you mean by fatigue or tiredness. What do you mean? How do you feel? And after you clarify that you find it is real fatigue, that there is no power, I can do nothing or so, then you have the map now. The map is the first question is the timing. Timing very critical here. This is timing. Is it related to specific time during the day or no? Okay, so if it's at the end of the day, so you have the most common and most obvious one is myasthenia gravis. Okay, so you have it and you have a 3 or 4 with it. You need to, if it's not myasthenia, you need to know whether it's chronic fatigue syndrome, fibromyalgia, or to some extent anemia. Okay, so this is the if the fatigue mainly in the evening. Okay, if the patient say no, I feel when I woke up, I feel unfresh, not fresh at all. I feel fatigue, and after that, I feel better. This is obstructive sleep apnea until prove otherwise. The second thing that it's come in UK centers is carbon monoxide poisoning. You need to ask about are you the only one has these symptoms, or anyone of the household have the same symptoms with you? So, or did you change your any renovation in the house? Sometimes in UK there is a new heating system called this carbon monoxide device, but usually it's unlikely nowadays. But put it, some old houses don't have this system. They have usually they have detector for carbon monoxide because very dangerous. So just put it in the morning. It's OSA, obstructive sleep apnea until proof otherwise. At the evening, it's myasthenia gravis on the top. If it's not myasthenia, put chronic fatigue syndrome, fibromyalgia, and anemia. Anemia is easy to exclude it quickly, but fibromyalgia and chronic fatigue syndrome, it needs to ask more question about the tenderness, a weakness, joint pain, and so recent infection, sore throat, and mood, other things. If the patient said no, I feel fatigue all the day. This is here. This point need to clarify more and more. How? By the weight changes. Weight changes, either weight loss or weight gain. Okay. If the patient said there is weight loss, so you need to ask about appetite. Okay. To divide both. If it's weight loss with loss of appetite, so you need to put the cancers. Okay, you need chronic infection like connective tissue disease like SLE. You need to put like
Serious infection, TB, and
serious infection. Yes. Chronic
HIV.
infection. Yes, connective tissue disease, cancer, and I guess Addison with them. Yes. I need someone to help me. Is Addison with them? Addison,
Yes.
and then
Addison
C's.
and CT.
Yes.
Addison
And
and CT. Chronic infection and chronic infection, the chronic disease and cancer.
I couldn't hear your voice. You
Addison and
agree?
CT. Chronic
Yes.
infection and cancer and chronic disease.
Yes. So if it's weight loss with loss of appetite, this is Addison, then 4 C's. Chronic infection, cancer, connective tissue disease. And if it's with good or no change in appetite, you need to put like hyperthyroidism, okay, like malabsorption, like celiac, like leishmaniasis, and this put celiac or malabsorption in general, okay, and hyperthyroidism mainly, and you could put anemia as well in this category. Okay, so if the patient has weight gain, so you need to ask about is it localized or generalized, and if it's localized, ask about where the acromegaly and Cushing. If it's generalized, you have this differential for hypothyroidism and metabolic syndrome, insulinoma, PCO, and simple obesity. Okay, this is the differential how to do a map for weight changes, and the same way it's to add to that the fatigue. So you have 2 maps here. Okay, this is Dr. Salah. Okay, Dr.
Yeah.
Salah way. Okay, I
Okay.
hope it's really helpful.
Yeah, helpful and clear, Dr. Natalia. Thank you so much.
Okay, thanks.
So you can correlate Dr. Mahmoud with the weight in some cases, with the duration in some cases, and seriousness of the condition, as Dr. Dalia mentioned. The weight is important, either gaining or losing weight. The diurnal variation and the early morning for the OSA. So the examples explain the condition itself. Thanks, Dr. Adelia, for the explanation and clarifying. Any
Welcome.
other comment or yeah, any other
Yeah,
comment or
before
question?
everything, with
Yes,
particularly
the
with
meaning.
cases, is to ask about past medical history before even analysis.
Yeah.
You could do that. It's really good.
Okay, thanks. Any other comment or question? Okay, Dr. Mahmoud. Difficult standing from sitting position. The test for kyphosis. Dr. Ihda asking for kyphosis. In history, difficult coming here. Yeah, could be there, yes. Any proximal neuropathy or in this patient with stiffness. Test for kyphosis. You no specific test, Dr. Ihda. You expose the patient back. Just expose the patient back, you will see his back curvature.
I think even the head heel test, I think it's test for the kyphosis.
Head wall.
Head wall, yeah.
Occiput wall, sorry. Occiput wall.
Absolutely, yeah.
Yeah, this for enclosing, yes. Occiput wall test, okay. Difficult standing prosthetic, yes, it's there, it was there in the case, okay. So if no more comment and question, let's go to the next scenario. Give me the patient
Okay.
name and complaint.
Yeah. Okay, we'll send it in the group or you want to?
It's okay if you can copy and put it
Yeah.
here, or if you want to send there and then copy, it's okay. Equal.
Yeah, I send it to the group because it's a picture, it's not writing.
Okay. I'll bring it.
Okay.
So Dr. Riba, I can't copy. Seems to be difficult to copy
Oh,
it.
you want?
Someone can write it.
Okay, we'll
Mr.
write it.
Alexander
Yeah,
Jones, 30
30 years.
years, 4 months history of diarrhea. That's it. No past medical history, lost some weight. We will start in 2 minutes, okay?
Okay.
Okay, I'm ready.
Yes. Okay.
Okay.
No.
Hello there.
Yeah. Hello.
I'm Dr. Mukhtar, the doctor in the clinic today. May I confirm you are Mr. Alexander?
Yes.
And how old are you, please?
Yeah, I'm 30.
30. Okay. We are here to discuss about your health issue. That okay for you?
Yes. Okay.
Okay. Can you tell me more about your complaint?
Yeah, really, doctor. Last time had a loose motion now since 4 months.
Okay, I'm so sorry to hear that, Mr. Alexander. And can you tell me more about that? How it started?
Yeah, it's really started gradually, and it was like 3 times, 4 times, but nowadays it's up to 7 or 8 times per day, and it's
And
really, yeah.
yeah, I'm so sorry, I didn't hear that. Tell me, Mr. Alexander, how was the usual or normal bowel habit for you?
It was just maybe once daily.
And what's the nature of this loose motion? I mean, what is it, watery or loose?
Yeah, it started watery. Yeah, it starts watery, but now it's loose, but there's some blood streaks in it the last week.
Okay, and previous to this, any previous attack of the same loose motion? I mean, before four
No,
months.
no,
Okay,
no, I wasn't.
and does it contain some slime?
No,
Is it offensive
no,
in smell? Okay,
no.
does it contain blood?
Yeah, it's really it's some streaks that I noticed last week.
Okay, any black stool?
No,
Is it related to the food?
no, I don't know that it's related to any food.
I mean, for the pasta and pizza, do you think it's related to them?
No,
Okay, and does it awake you from sleep?
yeah, yeah, sometimes.
Okay, does it alternative with the hard stool?
Um, no, this yeah, it's just loose stool.
Okay, and do you have any stress condition in your life?
Um, no, it's normal. Yeah, I'm third student, and there is no problems.
Okay, do you have any feeling sick
Sometimes, yeah, last week, sometimes feeling a little bit sick.
and difficult swallowing?
No,
Any throwing up?
no.
Okay, and how's your appetite?
Yeah, it's just decreased. Yeah, last week it's decreased less than before.
And the weight?
Yeah, I feel that in last 2 months, I feel my weight. I didn't measure it, but my pulse is looser than before.
Okay, sorry to hear that. Do you feel any lumps or bumps in your body?
Yeah, I have a lump in my neck.
Is it in
Yeah,
front of your neck?
it's yeah, in the front lateral. I don't know if you can see the picture, or I will describe this for you.
No, no, I can see. Okay, any difficult swallowing while eating from this
No,
lump?
no,
Okay, and any night sweating?
no,
Any night rise temperature?
Yeah, temperature is a little bit, yeah, for the last 6 months. I feel it's on and off, but it's not that high. It's maybe 37 around, or
Okay, how's your
yeah, it's
diet,
not,
Mr.
or 8, 38. Yeah.
Okay,
Uh,
how's your
you,
diet?
you mean,
Yeah,
yeah,
are
my
you
diet?
eating balanced diet? Balanced diet.
Yeah, yeah, yeah.
Did you use any herbal remedies?
No.
Okay, any travel history recently?
Yeah, last year I traveled to South Africa.
Okay, and did you eat a healthy diet?
Yeah, yeah, and just I stayed in
D-
5 stars
Yeah.
hotel, and yeah, it was.
Do you think it's related to the travel, the symptoms you have?
I don't know. Just it's some, yeah, symptom starts maybe 6 months back. I'm not sure,
Okay. Okay.
since the fever, but I didn't mind about the fever because it's not that high. But now the diarrhea is really annoying me.
Okay. Any history of cough?
No.
Any short of breath?
Yeah, nowadays maybe I feel a little bit because I'm feeling tired.
And this is with activity, I guess.
Yeah,
Okay. And when you're lying flat, you feel any difficulty of breathing?
no.
How many pillows you are using?
One below.
Any leg swelling?
No,
Any chest pain?
no.
Any heart racing feeling?
Yeah, a little bit with activity.
Anyone told you that you are paler than before?
Um, yeah, I'm really even maybe, yeah, maybe my girlfriend told me that maybe you are paler. Mm.
Okay. Do you feel dizzy while standing or sitting?
No, I'm okay.
And anyone told you that your eyes looks yellow,
Yeah, I have redness in my eyes. Yeah, it's 1 month back.
redness?
Yeah,
Okay. Can you tell me more? Both eyes? Is it in both eyes?
yeah, both eyes.
Any pain in the eye?
Now it's just red.
Any vision affection?
Um, I think, yeah, the vision is a little bit hazy.
Okay. Any headache?
No,
Any weakness?
no, just tired.
Any unsteadiness?
No,
Any pins and needles in your body?
any? No, no.
Pins and needles feeling. Okay. And any weather preference? Do you prefer any weather?
No,
Okay. And how's your water work? Is it changed recently or before?
no, no, it's normal. Maybe a little bit now, it's less than before, I feel, but
Is it darker?
a little bit darker, yeah.
Yeah. And it is frothy.
No,
Any skin rash or changes in the skin pigmentation?
no,
Any mouth ulcer?
no, but I have some yeah, white discoloration on my tongue.
Okay. And when it started?
Yeah, really, it's maybe 2 months back.
Okay. And you feel you can remove it by washing it by your hand or by your brush. It can be
Really,
removed.
I'm not,
You
I
didn't try.
didn't
Okay.
try this.
It's okay. Doesn't bother yourself. Any joint affection or pain?
No,
Any muscle pain?
no.
Okay. Any family history, same condition?
Yeah, just my uncle is had a colon cancer, so I'm worried if is this a cancer or
I appreciate your concern. I will address this concern at the end of this meeting. Mr. Alderson, you have partner
Yes.
and you have any casual relationship. Sorry to ask this question.
Yeah, sometimes.
Is it protected one?
Not always.
Okay. You have any long-lasting disease I should be aware?
No.
Sorry for this question. I'm asking to all my patients. Do you have any drug, recreational drugs, I mean, for sharing needles,
No.
any tattooing,
No.
any blood transfusion,
No.
any surgical operation done for you,
No.
any allergy to any medication,
No.
any over-counter medication?
No.
I will ask again a sensitive question. When was the last time you have unprotected sex? Sorry for this question.
Yeah, I think that was when I traveled when I was in South Africa.
Okay, okay. Okay, Mr. Sir, can I ask you what's your job?
I'm student.
And do you smoke?
Yes.
How many cigarettes per day? For how long?
Yeah, for now 10 cigarettes per day for 5 years.
And do you drink alcohol?
Yes.
So I can advise you to quit smoking, and if you don't mind, it will help in your condition here and in your general health. Is that okay for you?
Okay.
And for how many units you are drinking in the week?
Yeah, around 14 units.
Okay, can I ask you, sir, to moderate your intake of alcohol, please?
Okay, what's
Okay,
wrong?
may I examine you?
Okay.
I will start by general look, how he looks. Cachectic little bit.
Yeah, a little bit underweight.
And the body mass index.
Body mass index.
It's okay. So looks underweight. Okay.
It's underweight. Yeah,
Underbuilt.
underweight.
Yeah, okay.
Mhm.
Vital charts, blood pressure, temperature, and pulse.
Yeah, yeah, normal.
Normal. Any proximal myopathy?
No,
Any injection marks?
no.
So direct to the eye, the redness in both eyes. Any
Yeah, both
dryness?
eyes. No.
Any skin bruises or rashes?
No.
Okay, the neck round, I can check for lymph node.
Okay. Yeah.
There is lymph node. Okay. I examined the chest.
Yeah. Okay.
Any change in the auscultation?
No change in that position.
Okay. Any phlegm he has?
No.
Okay. The abdomen examination and for organomegaly and
Yeah.
hepatosplenomegaly.
No, there is no organomegaly. Just a little bit tummy pain, mild.
Any stigmata of liver disease?
No.
Okay. I will offer inguinal lymph node.
Yeah,
And
there is
there is
lymphadenopathy. Yeah, there
any
is
I will
lymphadenopathy.
offer examination of external genitalia and digital rectal examination for any black passage and per black passage.
Okay.
It's okay.
Normal.
Okay. Apical lymph node as well. Sorry, axillary lymph node.
Yeah, there's lymph node.
Okay.
Yeah,
Blood
right.
pressure sitting and standing, and may I know the concern of the patient?
Yeah, just I want to know what I have, doctor. Just I'm afraid
Yeah.
this is a cancer.
I appreciate your concern, sir, but cancer actually it's one of the possibilities being having a family history of cancer in the colon,
Mm,
but we are suspecting another infection rather than being cancer, which is HIV. Do you think you have HIV?
I'm really afraid from this since I came from
Okay,
South Africa. Yeah.
okay.
Mhm.
So it might be HIV. Time is up.
Okay. Yeah. So, okay. So summarize your case
Okay.
and
This patient, Mr. Alexander, 30 years,
mhm,
came with complaint of loose motion, diarrhea for 4 months. It's watery one, and the progressive worse being more increasing the frequency. Lastly, it's reached to the level of 7 times per day. It's not related to the
mhm,
food. It contains some streaks of blood and awaken from sleep. Uh, it's not containing slim or slime. He has loss of appetite along with decreased body weight and rising body temperature on and off around 38.
mhm,
He's pale little bit and by examination of the eyes there is red both eyes. There is candida or sorry white layer in the tongue, might be candidiasis. History of travel 1 year back, and he had history of and casual relationships, which wasn't protected one. Family history of cancer colon and smoker and alcoholic. By examination, he has he's underweight, and by the history also there was history of heart racing and short of breath while doing some exercise. Examination, lymphadenopathy, generalized in the cervical area, in the inguinal area, in the axillary area. No affection of the external genitalia, I mean. No signs of what else? Sorry, no signs of heart failure. However, I didn't examine the heart. Sorry, it's added by me. Okay, the vital chart was normal, but I missed also the examination of the dehydration signs since he has
Yes,
diarrhea.
dehydration. Yeah.
Yeah. Okay. Yeah, this is my patient. So the differential could be HIV, gastroenteritis, either streptosporiosis infection, opportunistic infection, I mean, or HIV. Yeah, HIV. That's called. I missed the name. Okay, gastroenteritis still my differential. My other differential, inflammatory bowel disease and traveler diarrhea, but being travel for a long time, it's against this. Yeah, this is my case.
And any other differential?
Yeah, cancer colon, of course.
Yeah,
It's
you said it to
important.
the patient. Yeah, cancer colon.
Yes.
Yeah, and for the HIV, which the opportunistic infection that may cause blood diarrhea, HIV, most common one.
Leptospirosis,
It will cause
cytomegalo.
yeah, cytomegalovirus. Yeah, it will cause
Cytomegalovirus.
red lymphadenopathy. Yeah, and bloody diarrhea.
Yes.
Yeah, and for the watery diarrhea, because it was watery and then changed a little bit to bloody in the last week. So there is a change in the, maybe it's a 2-in-1. For the watery diarrhea in HIV,
It's still opportunistic
It's fine.
infection, but the name of
Opportunistic.
organism you mean?
Do you know the name of organism?
The common is you mean or yeah, I need the name. Cryptosporiosis.
Yeah,
Yeah,
cryptosporiosis. Yeah, microsporiosis and cryptosporiosis, and maybe fungal. Yeah.
yes, there is also candidiasis in the tongue, and the mouth.
Yeah. And so, what's the investigation?
Yeah, starting by general examination, general investigation, basic baseline workup, CBC, inflammatory markers, kidney function, electrolyte, urea, creatinine, and liver function test. And I could do a screening for HIV antibodies and viral load and CD4 count. This is for HIV itself. I might add also tumor markers, CA19 to rule out cancer colon, CA as well. CA and CA, not CAS19, CA19 for pancreas, CAA. Carcinoembryonic antigen. Okay. Imaging, I could do screening for CT CAP, chest and abdomen and pelvis, searching for the lymphadenopathy, and I could consider lymph node biopsy to confirm the diagnosis. For the complication, yeah, stool culture and analysis.
Yes.
As well as fungal culture. And complication in the chest also, I could do chest X-ray to rule out any chest infection.
Yeah.
And that's it.
Yeah.
Echo
And
to
what
rule
about
out any colon. I could do colonoscopy.
Colonoscopy.
Taking, yes.
Yeah,
Searching
because there is
for
good
biopsy.
Yeah.
Yes.
And yeah, and what's the management?
Yes, multidisciplinary team approach, including infectious disease and oncologist if being suspected for cancer, gastroenterologist, ophthalmologist, and GP, specialized nurse, and social worker. Non-pharmacological patient education counseling about the disease and the complication and the seriousness of his condition. And for also tracing and some advice about I mean screening his partner or his family, and not to share the special private tools with his family to prevent infection. For the pharmacological, I could add for him after screening and doing CD4 count. If more than 200, we can add some prophylactic antibiotics, and if less than 200, there is also another prophylactic management. Immediately, we'll start him on heart, highly antiretroviral therapy. And for the complication, according to the infection growth, according to the culture. If he's growing fungal, we can start antifungal. If there is some protozoal infection, we can start for antiprotozoal.
Yeah, I think everything is covered. Maybe the one thing in the history, contact with TB, because there is lymphadenopathy and travel history.
Yeah.
So
That's
you didn't ask about the contact, and maybe sometimes miliary TB presented by diarrhea. And I think the history you covered everything. I don't know if the others have a comment. What else? Features malabsorption. Yeah, I think one of the differentials, maybe lymphoma. It can be.
Yes, sure.
Yeah. Mm-hmm.
Still under the term of cancer.
For different,
Yeah, you're
cancer.
right.
Yeah, what else? Yeah, I think you covered it very well. And it can be HIV, it can be inflammatory bowel disease, and the cancer is one of the suspicions. Lymphoma as well,
Mhm.
one of that CA colon and lymphoma.
Yes.
Okay,
I
thank
agree.
you, Dr. Basim.
Thanks,
So,
Dr. Heba, for the case. Thank you.
okay, welcome.
Okay, we
Anyone
can
has a
take,
comment?
yeah, please. Any comment, Dr. Yes, you can read, Dr. Heba. Hello, yes, who's talking? Sorry.
هو احنا بس لما نعرف ان في family history of cancer بيتهيألي المفروض نسأل عن at what age.
Yes, you're
عشان
right,
نعرف.
Dr. Shema. Yes.
Yes.
Amsterdam
بيتهيألي بقى
criteria, yes.
travel history
Yeah,
كان ممكن ناخد فيه أكتر من كده شوية.
you're right, yes. Amsterdam criteria, yes. How old his father when he did?
Yeah.
Yes, you're right.
Mm-hmm.
And how many
Positive.
family member he had the cancer?
Yeah.
Yes, you're right.
Yeah. Maybe familial polyposis, yeah.
Yeah. Okay, thank you, Dr. Shema. Any other comment? Any advice? Dr. Dalia, yes, sure.
What about celiac?
Celiac, actually, I wrote it in the differential, but I can't put it here.
Oh,
Patient has serious. No, you're right. If there is no alarming and
Yeah.
serious infection, we can put celiac, of course. I put inflammatory
yes.
bowel disease because it was associated with blood, this diarrhea, I mean. So I can put it
Yeah.
little extent can be accepted, but I think also the cancer, lymphoma, and TB, HIV, this is the top of the fringe. Yeah, patient
Yes,
is
if associated weight loss and constitutional symptoms.
his
we
risk,
can
and
put.
also risky habit he has multiple and protected sexual relationships.
Yes. Clear.
Yeah, thank you.
Yeah,
Okay,
even
Thank
if
you.
Dr.
Thank you.
there is no association with the food. Yeah, Weber
Yeah,
disease. Yeah, Weber disease more with the steatorrhea and but maybe
yeah,
there is no C. Yes.
it's a difficult case to be Weber disease, but we should remember it always whenever we
Yeah.
don't have explanation on the lymph node, but the joint pain will be there in the weapons.
Yeah.
It's associated with joint pain, yes.
Carcinoid. Yeah, even carcinoid maybe. Yeah.
Carcinoid will be as episodic. Yeah,
Yes, with a
and
flush.
it will be
Flush,
flush
flushing,
and
wheezes,
hypotension.
yes, as well,
Yeah.
wheezes as well, yes, you're right. Feature of Dr. Abdullah wrote features plus feature of malabsorption diarrhea. It wasn't there. It will be containing the slime if like that, but it's not containing slime.
Yes.
So lymphoma as well, Dr. Honaida mentioned. Yes, Dr. Honaida, thanks for the comment. Intestinal TB, exactly.
Yes.
Celiac complicated by lymphoma. Wow. Nice one. But still, the food relation is very important. I asked specifically about the food related either to the pasta or pizza. It's not related.
Yes.
So I can't put celiac here. Yes.
Yeah.
Weber disease, yes, Dr. Amin, we mentioned already. Joint pain will be there. When should we think of carcinoid, Dr. Abdullah, as case in approach? Flushing, it's triad, Dr. Abdullah, flushing, wheezes, and in attacks related to the substance release, and it will cause all these symptoms. Clear, Dr. Abdullah. Actually, the name of what is the substance, Dr. Hiba? It's The
Something
released, yeah, from carcinoid, I mean, which
carcinoid,
cause all these things.
serotonin.
Yeah, serotonin, yes, serotonin.
Serotonin, yeah.
And in the urine, 5,
It's 5-HAA.
yeah, highest,
Yeah,
higher.
Higher venous, 5 higher.
hydroxy.
Hydroxy-indole-acetic acid, yes. Hydroxy-indole-acetic acid. Yes, yes.
Hydroxy, okay. I'm
Indole,
just
acetic acid, yeah.
indole acetic acid.
Yeah. I'm memorizing like indole acetic acid.
Indole.
Yeah.
Okay,
indole
indole
يعني
acetic
أعطوني.
acetic acid.
Yeah.
Okay, indole acetic acid. Because I am me as well
Never
trying just
remember
to memorize this, but always forget.
No. Yeah, remember
Okay,
as
indole
indole
acetic acid.
أعطوني يعني yeah. Indole acetic acid, yes. Hydroxy indole acetic acid, yes. Indole acetic acid or indole whatever دكتورة
Indole
إيه
acetic
المهم
acid.
نفتكر. Yes. Okay. Indole acetic acid. Painful swallowing in history, Dr. Amin. Painful swallowing in history as esophageal candida is one of the pathognomic features of HIV. Yes, I asked for difficult swallowing. However, there is whitish layer in the tongue, which is candida infection. It could be presented with difficult swallowing and couldn't be. Sometimes without difficulty, sometimes with difficulty, according to the position. Maybe higher or lower could be. Okay.
Right, thank you.
Nice.
I want to ask please دكتور حضرتك سألت هي وشل ولا لا removable ولا لا عشان تفرقها ايه من ايه مش قادرة افتكر بس
What's your question, Dr. Shema?
حضرتك سألتها هي removable by washing or brushing فلا عشان تفرق بين حاجتين بس انا مش قادرة افتكر ايه الحاجتين دول
I think I will try to remember the other thing, but the candidiasis it's not. But the other thing I'm not sure what is it. But yeah, it's characterized by it can't be removed. Okay, we can search about it, or if someone knows, you can share with us. We always try to brainstorming the data. Oral hairy leukoplakia, Dr. Amin. So this one will be removed, Dr. Amin, right? Oral
bloody, one of them, removed with blood, I think.
The leukoplakia. Yeah.
I'm sorry, thank you. What was the eye manifestations in this case? What is it? Like what is it about it? Thank you.
Infection, maybe opportunistic infection. I'm not sure, but
yeah, it's
yes, Dr. Hiba.
Yeah, what they thought that in the cytomegalovirus, it's a triad with
pizza
red
eye,
red eye and lymphadenopathy with bloody diarrhea.
Yes, you're right. Yes. But I think with the retina and the fundoscopy, Dr. Hiba, not in
in fundoscopy. No, but there's. I just shared the picture of the eyes in the WhatsApp group. So it's like
from outside you can see it. Yeah. Even without fundoscopy. Okay, I agree.
Zigzag?
Yes. Sorry?
I said it like zigzag.
Zigzag?
Viral infection. Yeah.
What is the zigzag? The retinitis or the pizza retina?
Yes. Even apparent, I think, from some. This is what defining what of the viral infection of the eye. But I don't know, is it the cytomegalovirus or something else?
Yes, it's cytomegalovirus.
It's the same, yeah.
Yes.
Oh, yeah. Okay.
I didn't understand, Dr. Shayma. You wrote the voice is low for you or for who? The voice here is very low. I think the voice is clear for all of us. I'm not sure if. Sorry?
ما كتبتش حاجة
Okay, so Dr. If no more comments, no more questions. So your case was very nice, Dr. Hiba.
Okay, thank you.
Yeah,
Thanks for your
from
case,
our
and we'll not
brains. Yeah,
forget the polymyalgia
never,
rheumatica.
never,
Never.
ever. Yes.
Yeah, okay, thank you very much.
Most welcome, Dr. Heba. Thank you also for your case.
Okay, thanks.
Okay, I guess Dr. Rimaz apologize for the communication. Who's interested, he can do communication with Dr. Tanya.
Assalamu alaikum.
Dr. Ruda. Wa alaikum assalam. Yes.
Yeah, I will
Okay.
take it.
Yeah, sure, Dr. Ruda.
Oh.
Please, Dr. Tanya and Dr. Ruda, start the communication.
Okay.
Arrange together. Yes, please.
Dr. Tanya, I will post in the group.
Okay, you want to post first? Okay.
Yeah, yeah.
Okay, please.
Okay, Dr. Tanya, you're with us?
Yes, I am here.
Yeah, because the scenario is long. You can read, please, loudly.
3 minutes.
So,
Okay.
yeah, all of us, we can read here.
Okay, so you are a junior doctor in a cardio outpatient clinic. Mr. Patrick McDonough, 37-year-old builder and father of 3, who was admitted on the medical ward with a syncopal episode 2 months ago. Okay, a syncopal episode 2 months ago. He has been previously fit and well. Examination on admission revealed a normal pulse rate, but his BP was elevated, persistently 160 by 95. There was a soft ejection systolic murmur over the left sternal edge. His ECG was normal apart from large voltage complexes consistent with left ventricular hypertrophy. Okay, ECG was LVH. He was discharged and prescribed atenolol beta blocker for his hypertension, and arrangements were also made for him to have a 24 hours ECG and an echo as an outpatient. The 24 hours ECG was normal, but the echo demonstrated severe cardiomyopathy. So diagnosed as HOCM now with an outflow tract gradient of 50 millimeter of mercury, following which an urgent appointment for the cardiac clinic has been met. So his GP has told him that this condition can affect his family. He's concerned about this. Okay, so HOCM is typically an autosomal dominant disorder with very variable manifestations. Some people with the condition have no problem, but others die suddenly. Further investigation, that is the electrophysiological studies, will be advised to explain the diagnosis of HOCM and the potential genetic implications of the condition. Okay, give me 1 minute.
Yes, sure. Are you ready?
Yes, sir.
Dr. Rhoda, are you ready? Hello, Dr. Rhoda?
Yeah. Hello.
Okay.
Okay.
Timer, please.
Yes, you can see the timer.
Start.
Hello there.
Hello.
This is Dr. Akhtar from Heart Clinic today. Am I talking with Mr. Patrick McDonough, 37 years old?
Yeah, correct.
Okay. Mr. Patrick, today we are here to talk about some issues related to your health condition. Is that okay with you?
Please, doctor.
So, Mr. Patrick, do you want anyone to attend the meeting with you today?
I'm great, doctor.
Okay. So, before proceeding further, Mr. Patrick, may I ask you how much do you know about your health condition so that can be on the same page?
Okay. So, doctor, I have been admitted 2 months ago because I have a sudden loss of consciousness. It happened twice, actually. And they admitted me. At that time, they told me my blood pressure a little bit like increased. And I have a sound in my heart. And then they did a tracing for my heart, and they told me there is nothing to be like worrisome. And then after that they did for me like a gel test for my heart, and they told me that I have a condition called hypertrophic obstructive cardiomyopathy, and it's explained thoroughly by the doctors. And actually, doctor, I asked to see you today because when I read in the internet, and actually also the doctor told me that there is a risk for my children. I have 3 children, doctor.
Okay.
Yeah, I'm afraid to pass this condition to them.
Okay.
Yeah.
I highly appreciate your concern, Mr. Patrick. And may I know what is your expectation from our meeting today?
I don't know. Is there anything like? Is it like 100% sure that one of my children will get the disease? And if yes, how to prevent this?
Okay, Mr. Patrick, I highly appreciate your concern. So please be sure I'm here to answer all your concern today. So regarding your concern, before going to the concern, may I ask you that you know elaborately about, you have a good idea about the disease that you are diagnosed with?
They told me the thing that I know, that they told me there is enlargement in my heart and this affects its pumping ability. That's the thing that I came up with a meeting. But if you will elaborate further, it will be very great, doctor.
Okay. So let me elaborate this regarding this disease, and then please obviously be sure that I will answer your concern. So if you have an idea about the disease, so that you can have the further idea about your children, is that okay?
Yeah, please.
Yeah. So actually, Mr. Patrick, as you are telling, absolutely right, and I'm really sorry that you are suffering through all of this. Extremely sorry about that. Yes, you have that one of a heart disease. It runs in the family, where there is the, let me draw you for you. This is your heart. So there is a heart muscle actually. So in case of your heart, the heart muscle increase the thickness. So as the thickness is increased, so the heart it is unable to pump the enough blood to the surrounding body parts. Are you getting me?
Yeah, with you.
Okay. Yeah. Okay. So that's why you had, as you told, there was a fainting attack 2 times. You told me, and actually it varies. The symptoms varies from person to person. Some can have light symptoms like you had, like fainting. Some even, I'm sorry to say that it can be also life-threatening, sudden cardiac death. It can lead to suddenly that there will be a hard death. I'm sorry to tell about that. So Mr. Patrick.
Doctor, I feel great right now. I feel very great. Does this mean they gave me a tablet? It's called like atenolol. I
Yes.
assure you I will be very compliant with them. Does this mean that I don't need any further test, doctor?
No, actually, Mr. Patrick, as you will need further test actually to go with further treatment protocol, that what should be the treatment that is going on, is it good for you, or you need further more updated treatment, maybe surgical, or maybe any kind of device to put inside your heart. Okay, so that's why we need to do one kind of studies that we are telling, that electrophysiological studies. So the electricity, how it is passing the electric signals from your heart, we will study that. And according to that,
why, doctor? Why? You told me there is like just an enlargement of my heart muscle. Why you are going to study the electricity in my heart?
To know that your heart condition is totally okay and how it is working. According to the condition, the treatment protocol will be chosen.
Okay,
Am I
I
clear
understand.
to you?
Yeah, doctor. Doctor, I don't know. I'm starting to be a little bit scary. Am I going to die, doctor?
Please don't worry. I highly appreciate your concern. But if you are under our specialist team that we are already having, as you told, that informed with the heart doctor, and we are having with our specialized nurse and with a social worker, we are going to give you the plan that you are going on with. If you are regularly maintain that according to the plan of management of us, there is a very few chance of death. But again, it is very unpredictable. As I told you, that this disease actually very unpredictable. In different person react in a different way. Am I clear?
Yeah, doctor. And what about my children?
Yes, regarding your children, I'm sorry to tell you that each of your children actually, each of them have 50% chance to have this disease. Okay, so
okay, doctor, my eldest son, he's 2 months and he will enter his 10th birthday. And I have also two daughters, about 4 and 5. So, so doctor, what's the plan, doctor?
Mr. Patrick, actually, what we can do, that we can refer all of your children to the genetic counseling team, so that they could be with the screening. If because this screening is not in any kind of invasive procedure. Usually, with the imaging of the heart, the screening is done. So there
you mean the same gel test you did for me?
Yes, it can be by the heart tracing, like ECG we are telling, or by the image of the heart that is telling the echo. So yes, it can be done. Okay, so but according to age, there is like gap that it should be done 3 yearly before puberty, and yearly from puberty to 20 years.
So doctor, why just not doing a blood test to see if they have this problem or not? I think it is more accurate. Is it more accurate?
I highly appreciate your concern, Mr. Patrick. That you are telling that blood test, I think you are telling about the genetic test of specific chromosome. Actually, if already the screening test with the heart imaging and that heart tracing, it is enough to diagnose. Because before doing that symptoms appearing, it will appear in those pictures, okay, in those tests. So that would be wiser to get, if you can do it something with non-invasive, why for going for something chromosomal, or maybe they will not have the symptoms. Okay, maybe they are positive, but they will not have that heart muscle problem that you are having. Are you getting me?
So the thing that I understand, they may have the genes, but it is not necessary to have the symptoms.
Yes, it could be maybe later on their life, or maybe very lightly they will have the symptoms.
Yeah.
Are you getting me? So we will keep them
Yeah.
under follow-up. We will keep them under follow-up every certain period of time. We will following them up, that they are developing or they're going to go any complication they're going
Okay,
to
I
develop.
understand.
Yes. Okay.
I understand.
Okay. Do you have any other concern, Mr. Patrick?
No, doctor.
Okay, so Mr. Patrick, do you smoke?
No, I don't.
Do you drink alcohol?
Never.
Okay, that's very appreciating. So may I know what's you're doing for your living? What's your job?
I am a builder.
Okay, so you are a builder. So does this disease affecting your job life?
No,
I mean,
I'm
is
all
it?
right. I'm all right. I think the time up.
But
Yeah, time is up. Yeah, I was waiting for the last concern, which is a builder. So
Okay.
how
yeah,
you can
so
answer
yeah.
this concern? Yes, please answer it. Then
So
we
as
finish.
So as you were builder, I suppose that you have to carry some heavy things. If you have to carry some heavy things like vigorous strength sizing type of things, so I would suggest you to not go for that, as this will affect your heart. As you know, it cannot get that much load. Are you getting me?
I understand. Yes, I understand.
So I will refer you to occupational health worker, and they can refer you to somewhere else where there will be associated with more official or desk job that will suit you.
Okay, excellent, doctor. Thank you.
Okay, thank you so much. I will give you some brochures regarding this disease more, and also about about how to run in family, the genetic tests, and following up, so that you can be more worrying of. Okay.
Okay, thank you.
Okay, thanks, Dr. Tanya. Thank you, Dr. Roda, for the scenario. Actually, it's a long scenario with full of concerns. Yeah, and one also of the common scenarios in the exam. One of the commonest genetic screening and counseling scenario in the exam. Yeah, thank you for this scenario, Dr. Roda. Please, your comment for Dr. Tanya.
Okay. She did great, as usual. And regarding the concerns, all the concerns answered correctly. Regarding in the introduction, I think no need to say if do you want anyone to attend the meeting. And yes, for the first concern, when I asked her, I feel great right now. Don't I need like any further test? Yes, you need further tests. Discuss about your future plans. What she means, the doctor, she means like she need like electrophysiological studies or like a cath or something to discuss about the ICD, and this will be later in further meeting. Yes, she answered very well. Am I going to die? Yes, there is a probability that is one of the complications, but assure the patient that is why we are going to do like a further test and to see if you are eligible for surgery or to insertion of some devices to prevent this from happening, and we will keep you under great follow-up on that. Regarding just the children, yes, they need to be screened by the echo, and this starting from the age of 10. And better she refer them to the genetic counselor also. What else? Regarding the job, yes, excellent. She told like this because they need to avoid vigorous exercises. Otherwise, she did great. No comment.
Okay, thanks.
Regarding the blood test, as we know all, the blood test is not like accurate. It will give like a result that might not be necessary to have the symptoms, and that's it. Thank you.
Yeah, so the same her answer. Yeah, thank you, Dr. Roda. Yes, I think I can't also add comment. Dr. Roda covered the comment. Apart from invitation, so we can say for the the breaking bad news in genetic disease not to invite unless the patient asks, because this is here confidentiality. You can't invite for that. Breaking bad news for disease, for something else, for infection, for apart from infection by HIV. So HIV or some sexual transmitted disease or genetic disease, don't invite. And if the patient conscious, of course. I mean, you are talking about the father, and the father is aware or conscious. So you should get permission and don't offer someone to attend the meeting to be a third person with you. Apart from this, I will just remind us and others for the comments and for the concern. So the explanation, you ask her what you know, and at the level she ends, you can go ahead, continue or explain from this point in order not to waste time explaining the disease from the start. Okay, so if she told you I have thickness in my muscle and so on, so it's enough. If she understand that and she want to know more, explain what could happen with the symptom, the signs, the manifestation, and the complication, and so on. And the concern, first concern, electrophysiological study, yes, in order to decide either for device or not. The depth different from person to person. I like this answer. Yeah, it's different. Maybe even the HOCM itself, from two HOCM disease patient, it will be different in symptoms and signs. So it's different in both. This is the answer for will I die? I'm afraid to say, yeah, there is probability. However, there is a variety of this disease in certain patients. So it's not present, or the same disease is not present with the same manifestation in the same group of disease. The children screening, yes, at the age of 10, as Dr. Roda said, but I think Dr. Roda also previous to 10 years, they are screening. There is echo for this child or children.
Yes.
Yeah. Blood testing, yes, because it's invasive one and we can screen without doing this blood test. We can do scan or gel scan of the heart. It will show us and it will give us idea about the manifestation in the heart of the diseased person. So no need to go invasively to do a blood test. And the same end result can be diagnosed by scanning. Smoker, alcohol, builder, and you can also for the hobby. If the patient has some hobby like playing football or playing some sports or going to the gym, there is lifting heavy objects, it's the same as well as the builder job. And also in the builder job, he is risky to have an episode while he's in the building. He might also fall, and it's also threaten his life. So it's either by lifting heavy object or having the syncope or the attack or arrhythmia while he's up and he might fall down. So it's risky for him by anyone. By all means, he can be better to be reallocated to another office job by occupational worker. So it was also good choice to offer here. Okay, thanks, Dr. Tanya. Any comment, Dr. Roda? Any comment from others?
Yes, what are the indication of screening children before the age of 10?
Yeah, still the same if the patient is already diagnosed. So you mean as the symptoms or what?
I mean, what are the indication of screening people for HOCM even if they have a family history before the age of 10? Like
I
by doing
remember,
genetic screen.
yeah, I remember, not genetic, even echo for babies. There is also screening by echo. I remember if the patient has family history of young cardiac arrest patient, I mean the father or the uncle died early age, so it's indication to screen for the siblings and offsprings. even they are younger. So the
Yes,
younger
yes.
presentation, yeah, the younger presentation, the younger also screening.
Before
You know,
puberty, they're doing the ECG or echo 3 yearly, and from puberty to 20 years, they're doing it yearly, every year.
yeah,
So it's
but still they can do it before 10 years. I remember Dr.
yes, yes,
Rhoda.
yeah. Before
If the
puberty,
child
3
is
yearly.
symptomatic, if the child is
So,
symptomatic and they have first degree
No, this is
diagnosis.
screening, no? Even with no symptoms, just for screening.
yes,
Before
he
the
might
age of 10,
present with cardiac death. Think about seriousness, Dr. Rhoda. If the child with running, he had this attack and he might be die. So why you
yeah,
are waiting for that? You can do screening as soon as possible. Once you discover and diagnose the father or the sibling or the offspring, screen for all because you can prevent the complication. You can prevent the cardiac death or cardiac arrest. Why not to screen? If you want not to screen, why you don't want to screen? It's non-invasive test, and it's totally prevented disease either by medication, by antiarrhythmic, or even by ICD. So you can prevent this complication. Is it clear now?
Okay. Okay.
Yeah. So the young also can be, or the children can be. Okay, let's, if no more, let's read the comments.
Dr. Basim,
Excuse me.
thank you.
Yes,
Well, just
yes,
about the, I'm sorry, can you repeat again about the confidentiality? You mentioned HIV and the father. I don't.
HIV, yeah, HIV and genetic disease. Don't invite another person to attend, and he will know about the disease, either genetic, and he will know about the infection. So it's out of confidentiality of the patient. Is it clear now? Yeah. And if you are talking about the father, and the father is awake, still alive, his capacity is okay, don't invite the son or don't ask the son to invite someone else to hear about his father because you just take the consent or the approval from the father to talk to the son. How you
Yes.
are going to invite someone third to hear about his father condition?
Yeah, the next in kin meetings. Okay, okay.
Yeah, this is the point of next of kin. Yes, exactly.
Thank you so much.
Doctor,
Yeah,
please, I want to
Mr.
ask. I
Yes,
want to
sure.
ask you, Doctor, please. Here, the electrophysiological study is mentioned in the scenario. So I should explain it in detail.
What the study show? Sorry, I didn't read it well. Can you read it?
Electrophysiological
Yeah,
study
yeah.
mentioned in the scenario. So should I ask to explain it in detail?
As Dr. Tanya did, you mean?
Uh,
So
or
what Dr. Tanya did, she correlate the electrophysiological study for the plan of ICD. I am not sure about the scenario, but this is what I understood from here and from the scenario. I didn't read the scenario well, actually. Is it like this, Dr. Roda? The electrophysiological study here, the indication to do ICD?
No, hello?
Yeah, yeah, we can hear you.
Yeah. Regarding the electrophysiological studies, like for Dr. Shaima, no need like to explain. Just touch it, like Dr. Tanya said. And
touch
if they, yeah, just touch it because it's written in the scenario. This is according to my vision, yeah. And regarding the electrophysiological study, like Dr. Basim said, it is not like indication for ICD or not, by the way.
It's not
It's not
indication.
انا السؤال اللي بساله يعني هو تاسك من التاسكس اللي عندي ان انا اكسبلين الالكتروفيسيولوجيكال ستادي ولا بس only touch.
Don't explain it, just touch it, like say it like Dr. Tanya said.
So
It is
it's
not
not
your task here.
yeah, but is it the decision for ICD or not? It's not related.
No,
This is
no,
so it's not because Dr. Tanya correlated with the ICD. After doing the electrophysical study, we will decide for ICD. That's why I thought the scenario like that, because I didn't focus about the scenario clearly.
Can you share the scenario again, please?
Yeah,
Okay,
it's
wait,
written in
wait,
the
I will
scenario
share.
like that. Like
Li-
yes, you decide for ICD, but in practice, I
But
think it is not related to the ICD. I
okay,
think so.
let's see the scenario. You can see my screen now. Yes. Okay, where is the point of ICT? How come typically autosomal, is it here or the second paragraph or the third? Echo outpatient arrangement. 24-hour ECG normal, but electrocardiogram demonstrates severe HOCM with outflow gradient 50, following which urgent appointment for the cardiac clinic has been made. GP told that the condition can affect. No, I didn't find this sentence. Condition, yeah, last,
before the task.
yeah, before the test. HOCM is typically an autosomal dominant disorder, which very variable manifestation. Some people with condition have no problems, but others die suddenly. Further investigation, for example, electrophysiological study will be advised. So it's not related to ICD. It's only to be, yeah, it's only to be mentioned as a test to be done only. But Dr. Tanya actually correlated with the ICD. Yes, Dr. Tanya, tell us.
Yeah, actually, EPS is testing why they have mentioned. I feel like this is what we are doing. We are doing the electrical activity of the heart. If there is any heart rhythm problem, right? According to that, it will determine that what should be the most suitable treatment for her, for the patient. Maybe it is ICD, or maybe they want to go for surgery. So I just told that to determine the mode of the treatment, what should be his treatment plan. That's why the EPS study, I felt like this is the only way, right? Why they are doing
So,
EPS,
so we
right?
can stop at this point and we can invite some cardiologist to explain for us.
Okay.
Actually, I am not sure as well. But it's not written here, but I don't know. Is it right to do? It needs some expert cardiologist to explain for us, really. I'm not sure. Dr. Dalia, you have any idea about this? I'm not sure, really.
Yeah, hello.
Yes, sure. Yeah.
Yeah, for EPS, usually what they do, this is the information that I know, that EBS will see if there is any foci for any arrhythmias. So if they found the foci, they will plan for application. For example, if they found here, for example, for atrial flutter, for atrial fibrillation, but particularly for atrial flutter, very important. Sometimes they found that there is foci for this arrhythmia, and they plan for ablation, and they do ablation, and then it could be curable. In such case of HOCM, they have high risk of arrhythmias, so they will see if there is any foci for that. Okay, because it's cardiomyopathy. So cardiomyopathy, it's very vulnerable for any arrhythmias. If they found that and it's amenable for any ablation, it's okay, it's fine. But if not, and if they didn't find any area, they will think about, for example, for ICD, or for if it's suitable for myomectomy, it's for myomectomy. So it definitely would help. It gives this, if there is ablation, okay, they do ablation. No ablation, so they will seek another kind of treatment. This is just from, I'm not, I didn't work in cardiology, okay, but this is from, yeah, the general info, yeah, general
Yes.
informations.
Yeah.
Okay. The other thing I want to talk about, it's regarding the concern about the testing, genetic testing. Sometimes we need to be clear that it's genetic testing, some kind of familiar disease, the imaging is superior to the to the any kind of genetic testing. And even it's needed by the family, it's for the kids is not they are not amenable for any kind of genetic counseling. There are kids, so they need to be 18 years old, then could apply for or could go for any counseling for their diseases. So it's not it's legally no children for genetic testing. It's just from 18 years and onward. Okay, so before that, usually the HOCM, that is yes, the HOCM, even for the as Dr. Dania nicely mentioned that sometimes if it's positive, there is for genetic testing there is false positive and false negative. We need to clarify that it's we can't say for the patients or candidate this is a false positive. It will be very difficult for them. So we could say if it's the patient say this is positive mutation or positive test, that is not mean that we'll definitely get the disease. And the opposite is right. If it's negative, that doesn't mean that you wouldn't have the disease. Okay, so there is some kind of mutation. Not all mutation will be tested, and so on. And in your case, the imaging is superior to the genetic testing for HOCM. Okay, so this is advisable, and usually it's from teenagers. Usually, I guess the earliest is 10 years because there are some kids, they will be teenagers at 10 years. So usually it's teenagers up for screening for echo. I guess that's all. Thank you.
Yeah, thank you, Dr. Daria, for giving a more clear explanation about the case and the genetic testing and the electrophysiological study. So, Dr. Tania, we can, in this scenario and this condition, we can just mention the electrophysiological study and give the options of management without specifying what could be the line of management. It's not only ICD, yeah, there is a lot of choices, yes, can be done. Okay, clear till now. Any question, any concern, or shall we move to the next scenario? Driving. Dr. Amin asked for driving in HOCM patient. I guess HOCM will not be banned unless he did some surgery. And as long as he's not having syncope while sitting or in rest, because driving is not that heavy or difficult job to do. Unless he's heavy vehicle driving, I guess this one will be banned. Okay, let's go to the next scenario. Dr. Tania, can you write scenario for Dr. Rhoda? Mr. Smith, 50 years. Yeah, okay. Dr. Rhoda, Mrs. Smith, you want to read the scenario? Can you read it for us loudly?
Yes, okay. Mrs. Smith, 50-year-old, known case of COPD with respiratory acidosis, unconscious, started NIV. Son agreed DNR. Now the patient is better and fully conscious. To tell her about DNR decision to continue or not. Refusing ABG also, to explain her the importance of ABG.
Okay, take 2 minutes, then we'll start.
DNR decision. Dr. Tania?
Yes, dear.
What's that mean? Is it like in the scenario, like DNR decision to continue or not, or what you mean?
Actually, this is the same copy and paste that people are sharing. I think this is one, case just appeared recently in a
Yeah,
center.
so Yeah,
This
yeah.
is in
Be ready for
Dubai Center.
surprise. Yeah, be ready
This
for
is in
surprise, doctor. Yeah.
Okay.
So it's new scenario, and in case
new
it's not
scenario,
clear,
Dubai.
yeah,
Came in Dubai this Saturday, 25 second cycle it came. And the same way they actually copy pasted.
Okay,
okay,
fine.
good. So you're lucky,
So I
Dr.
want to
Roda,
discuss.
yeah,
I
nice
all want to
new
discuss. This
scenario.
is new for all of us, I think.
Yeah. So be ready for any surprise, Dr. Roda. Prepare all the possible scenario and be ready and use your weapons how to shoot against the surprise, how to answer
Okay.
it. Okay.
Speaking
Yeah.
to the
Take
son
your
or
time.
to the Mrs. or Mrs.
Yes.
Smith?
The sun. The sun.
Okay.
No. Now you are talking with Mrs. Smith, the patient.
The patient.
Now
Now
patient is better. The patient is better and conscious. He was unconscious before. And now to tell her that the DNR decision actually before what I understood, that when he was unconscious, the treating team decided that we will start, we will do DNR. Then son agreed.
no. Yeah.
Then now
Now it
patient is
changed.
better. He
Okay.
is conscious now. So now this decision will be there or not. And patient is refusing ABG. That is different part. But I think the DNR issue is the most confusing one I felt. I also want the answer.
Yeah, clear now. Are you ready, Dr. Roda?
Hello.
Hello there.
Hello there. The time started or not?
No.
Yes. Hello there. I'm Dr. Zain, one of the doctor covering the service today. Am I talking to Mrs. Smith, 50-year-old?
Yes, doctor, Mrs. Smith.
Yeah. We are here to discuss issues related to your health condition. Is that all right?
Yes, doctor.
At any point, if you have any kind of concern, just let me know. Is that okay?
Okay, doctor.
So before starting to be on the same page, how much do you know about your health condition?
Oh, doctor, really, I had a terrible thing in my life. I have some lung disease since many years. So suddenly, actually, it get deteriorated, and I cannot remember actually what happened since yesterday. So now I'm here. I want to know what happened with me.
And how do you feel right now, by the way?
Now I'm okay.
Okay. So what do you expect? What do you expect? What happened? What do you expect?
Doctor, I want to know what happened. I think I lost my sense. Why do I lost my sense? And what happened? My lung disease got worse. Actually, I want to know what is going on with me.
Okay. Thank you for sharing this information with me. I do really thank you. As I understand that you have a condition called chronic obstructive pulmonary disease, and I assume you have a good idea about the disease. Am I right?
Yes, yes. This is I'm having since last 15 years. I know very well.
Yeah. And your condition suddenly get worsened. And when this condition get worsened, one of the gases in your blood, we call it CO2. Don't bother yourself with this term. It's become like accumulated in your body because your lung cannot get it out. And this affects your consciousness. And that is why actually your consciousness become disturbed and you lost consciousness. Are you with me, Mrs. Smith?
Yes, yes. Now I understood. Yes.
Yeah. And we attached you at a part of the management. We attached you to a machine. I think you have got a good idea about it. We call it non-invasive ventilator. That is the mask that attached to your face and attached to a machine to help you breathing. Do you have a good idea about it?
Yes, doctor. Previously also 2 times it happened. I used that machine.
Yeah. And actually, because you lost your consciousness and your condition gets worsening, and you have it for many years, like 15 years, and advanced. And actually, as a medical team, when we reach this point, we thinking about what is going to be next step in the patient management. And it's a kind of a difficult situation, and something, and think to decide. Are you with me?
Yes, doctor.
Yeah. And at this point, we reach to what is called as do not resuscitate. Have you any idea about it?
No, doctor. What is that?
Okay, we'll explain in a minute. It's when the condition of the patient gets worsened and this non-invasive ventilation not efficient. We avoid attaching the patient to a breathing machine and inserting tubes to his lung. And are you with me?
Yes.
Yeah. And also, if his heart stops, we avoid doing any kind of heart massage. Are you with me?
Oh my God. So, doctor, you guys decided to let me die?
I do really appreciate your concern. Actually, this decision taken by the consultant and for your best interest of you, because when people with advanced chronic obstructive pulmonary disease reach this point to which they will be attached to a breathing machine, we call it a mechanical ventilator, don't bother yourself with the term, and to the point that their heart stop, it means that his condition or heart condition become so advanced, and hence even if they made it after they become attached to this machine or after doing a heart massage, they will have a poor quality of life. And even it is very difficult to get them out of this breathing machine because their heart and lung are very weak to get them out of this. Are you with me?
Yes, doctor, I'm with you. I'm shocked actually.
I'm really sorry for this kind of news. Mrs. Smith, you, are you able to continue?
Yes, doctor. Okay. Continue, please.
Yeah, and I want to tell you that this attachment to a breathing machine, and in your condition specifically, it's very difficult to get out of it, and you may develop like a complication of a bug infection transmitted through these tubes inserted into your airways, into your air pipe. And another thing, the heart massage itself, when it's done, it may like break ribs. You may have a bleeding. All of this, on top of all of this, your heart, your lung is weak, and your probability of getting out of this is very low compared to other people. Are you with me?
Yes, doctor. Yes.
Yeah. And actually, we told your son about this decision, and he agreed. And I want to assure you that this decision is a medical decision. That the next of kin, I mean your son or any one of your relatives, even if he refuses, this is not their decision. It's a medical decision, but in our medical practice, we need to involve the families to share decision. Like this will make things more easy and in managing our patient. Are you with me?
Yes, doctor. So, what about now? We will continue this decision?
I do really appreciate your concern. Actually, thank you for bringing this up to me. I would like to ask you before this answering this concern, have you had any kind of a document in which you wrote your wishes in case you have lost your capacity? I mean, in this specific decision in itself, this do not resuscitate?
No, no, no. I didn't write anything.
Or do you have anyone on your behalf to take your decision? We call it lasting power of attorney.
No, doctor. No, doctor.
Yeah, because actually the decision of do not attempt to be resuscitated, better to be like an advanced decision with the patient itself. This will make for the medical make things for the medical team more easier. And regarding if will be the case in future or not, actually things change and your condition has changed. And this is what happened in the medical practice. And we don't know if you got this condition in future, what is going to be the decision. And that is why it is a kind of a difficult question to be like answered right now. Are you with me?
So you don't know that you will going with the decision or not next time?
Yeah, it depends on the patient case. It depends on his blood pressure, oxygen saturation, his response to the medical management, his consciousness level. All of this change. Are you with me?
But if I want to have that you are telling, that resus something, if I want to save my life, so what would be your decision? You will not save me?
I do really appreciate your concern, really. Actually, the decision of do not resuscitate, that we abbreviate it in medical term DNR, is a kind of a medical decision. It's you have the right of refusing it. but you do not have the right of asking for it, because this kind of a decision is made by the consultant for your best interest, and is a kind of a medical team decision. Are you with me?
I am with you, doctor. Okay.
So I want to ask, do you have any other concern?
No, doctor. No.
Yeah, and they told me that we need to take from you a sample. We call it arterial blood gas. We abbreviate it as ABG. And they told me you are refusing. May I ask you why?
Because you know already I have so many needle prick. I don't want any more needle prick. It's enough. And last 2 times, this staff nurse, she tried and it was painful. I don't want.
I'm really sorry for what you have been passing through, this pain and all of this. Actually, this kind of sample is very important, especially in your condition, because people with chronic obstructive pulmonary disease, as I said, they may have gases retained inside their body because they cannot get them out. For example, this CO2, don't bother yourself with this term. And to know its level in our blood, we need to take this sample. It shows what the number of this gas in your blood, to prevent any risk of losing consciousness again. Mrs. Smith, are you with me?
Yes, doctor, yes.
Okay, and regarding the needle pain, we will make sure that we will numb the area, we will clean it very well. We may bring even the nurse manager to take the sample from you after taking her acceptance. And don't worry, we will make this to feel a little pain as much as we can. Is that all right?
Okay, doctor. Okay.
The time is up. Yeah.
Okay.
Time is up. Thanks, Dr. Ruda. It's a new scenario with a new concern. Dr. Tanya explored to us a lot of concern in this scenario. Yes, please, Dr. Tanya, comment, then we will comment.
Yes, doctor, you did really, really, really great. How it started, and every single concern you answered me very, very nicely, and I couldn't do better than this. Excellent. I felt like you went through the right way. Regarding the DNR of last ending, that it should be continue or not, you have answered it very nicely, diplomatically, that this will again depend on the condition of the patient, because they cannot ask for resuscitation. The patient cannot ask for any kind of treatment. They can refuse that. So yes, resuscitation, DNR, they can, I mean, do not resuscitate. They can refuse that, I don't want resuscitation, but they cannot ask that I want resuscitation. So if the condition is so advanced, and every single thing you mentioned very nicely, even it is so new case, you were so confident, and mashallah, yeah, I love the way you elaborated everything. Really, I don't have any single I mean criticism from the scenario. Very well done, very well done.
Thank you, Dr. Tanya, for the positive comment. By the way, whenever I am commenting, just to repeat the point and try to remind us and to remind the candidate about the missing point. But all of us here doing great, all of you perfect, and actually I'm proud to practice with all this group. Thanks, Dr. Tanya, for the case again. Thanks, Dr. Roda, for the practice. Actually, I wrote the point with you while you are practicing. The introduction was great. The knowledge about the condition and the expectation. Then anytime you can ask me to stop and to ask me, how do you feel now? What's a good question, just to prepare her for the coming shocking information, which is DNR, which was signed while she was in her awareness, or she wasn't in her sense. So it was the best interest for her condition. Again, if the patient became okay, still the DNR will be still there, because we will not allow you to suffer more. We don't want you to suffer. We want you just have a good quality of life if you will survive. This is for the heart massage only if or in case of heart stop beating. Apart from this, we will give you all the maximum support. We will give you the oxygen, we will give you the feeding, we will give you the antibiotics, we will give you everything you need. Only in case of the heart stop, we will not jump to your chest to do heart massage. This is very important, and it's also important to our colleagues in the hospitals. Some doctors misunderstand the DNR, like we will not touch the patient after we sign this paper. No, it's not. So the paper mean, or the DNR mean, will not do chest compression or will not do heart massage in case the heart stop. So the bug infection and some disadvantage, pros and cons of the ventilation you mentioned, well, Dr. Roda. The bug infection, the ribs fracture, the heart massage, and the harm of this, bleeding, it might be also there. So it was a medical decision in the best interest for your condition. Advanced directive and lasting power of attorney, quick, you can ask. Yeah, but I don't think you can ask for lasting power of attorney because it's already decided. So you can ask for wishes only. Do you wish for anything? Do you comment for any living wish in case of? But the lasting power of attorney, even while he was there, he didn't change the decision. So no need to mention him. And the point of ABG, it could be earlier to start because it was of this task. Better to start it even before the advanced directive, because the patient concern was refusing the ABG, and the option you give was great by asking the perfect or professional nurse to come and take the blood gas, and it guide us how to deal with the change of the blood gases, which is carbon dioxide in the blood, which can lead to the same presentation which you have earlier. So I believe it will be better to explain and to address it before asking for advanced directive, because it's in the task. ABG was refused by the patient. Any other comment or any other question for this scenario we can receive all? Thank you for bringing this scenario. Yes, thank you, Dr. Tanya. Better to give DNR in breaking bad news format. Dr. Rhoda.
Thank you.
Yeah. Yeah, explain. I don't understand what you mean.
I mean, I think better like to give her the issues that was taken for a DNR for her in a break bad news mode.
Yeah, in the same time, yeah, earlier you mean.
It's
Yes.
a difficult decision.
Yeah.
It was a difficult, yeah.
I agree with you. Yes, you can do it earlier, and it will ease the DNR, because if she said, "I don't want to suffer, doctor, from this ventilation or this machine, which is called breathing support machine, in case of failure of my breathing," so it will ease that task for you. So better to start, not to start. I mean, while discussing the DNR itself, you can add it as if you want to add something to this point, yeah, you can do, and it will ease the scenario. I agree with you. Yes. Any other question or any comment?
Could
Dr.
I
Dalia,
comment?
yes. Yeah, sure.
Okay. So well done, Dr. Rudaya, as outstanding as usual. Thank you for your performance. Thank you, Dr. Tanya, for the case. I just want to, I have already sent a copy from the kind of decision. This is paper in the front of DNR forms, you know, you could, this is from the Word, okay? I've take a picture for you all to help you for this kind of decision. And I guess this is, now I took this for you, it's in the right time with this scenario, okay? So what I like, yeah, I like all things except two things, according to this. The first thing is that you did well, but you talk a lot, you give more information, and that you could be more, because you didn't complete your task. This is why, because you have another task is to discuss why the patient refused ABG. So the time finished before you finished your task. The only thing here. The second thing, after the patient said to you why she disagree the decision of DNR, you've mentioned to her that is kind of confrontation. Okay, you told her that this is a medical team decision, and this is like this. It wouldn't be like this. I know sometimes we need to be firm. We need to do that, but usually, if the patient, this is decision should be between the patient and the doctor. And if you feel you can't convince her about this decision, according to the guidelines, is to say to her, do you need any second opinion? It might help you. For example, you could just suggest that we could arrange another meeting with the consultant. Okay, is that all right to discuss more about that? Okay, this second opinion, this is written here. You could read the pathway. Okay, it will help you a lot regarding this. This is all option is written here. Any scenario will be very clear for you if you read this. So if you start to read this, you will find that the patient has the possibility of successful CPR will not be here in this kind of patient, yes, because this patient is already COPD with what? With respiratory failure type 2, yes, because this carbon dioxide retention, okay, and now develop respiratory acidosis. So this patient is COPD with respiratory failure type 2. He is conscious and recovered, but unlikely to be. For this kind of patient with advanced COPD, usually they will put DNR for them, okay? Because to be recovered is unlikely, and unsuccessful CPR would be. So you could go down for the orange box, and you go for no chance, and then you will find if at the end of last two lines, if the decision is not accepted by the patient, the representative or those close to them, a second opinion should be offered. Okay, يعني البيشنت ولا أهله ولا الناس close to them رفضوا الحاجة دي, second opinion should be offered. You have to offer a second opinion to the patient, to the family. Okay. I hope it's helpful for you.
Yes,
And
Dr.
that's-
Dalia.
Yeah. Clear, Dr. Dalia, yes.
Yeah, Dr. Dalia, so regarding the patient who said, if this happen in future, does this DNR will be again for me? What should I tell her?
Usually with chronic disease, their prediction of that, but usually DNR, it's usually could be reassessed with each admission. Okay,
Uh-huh.
Sometimes,
Yeah.
sometimes CPR will be something constant because the whole situation of the patient is constant. For example, patient have poor quality of life, bedridden, about to for example, has for example, advanced MS and bedbound and has many other comorbidities, and this is unlikely to be recovered. At the same time, poor quality of life and many things. So this usually, even sometimes, the decision is made community-based from the GB or something, in case he has many carers with him at home. Okay, so sometimes it's very obvious this patient is for DNR. And sometimes there is patient, for example, they have COPD and they develop a very unlikely to be recovered from, for example, septic shock, or unlikely to recover. Or sometimes this kind of patient with severe exacerbation of COPD, and even with many attempts of treatment, or the patient didn't respond well, and is keep deteriorating despite all the efforts. And this is at this admission, the patient is for DNR. Sometimes is the decision about the admission. Each admission, sometimes the circumstances change. For sepsis is unlikely. The mortality rate is very high, especially if the patient has other comorbidity. And sometimes you find that the patient his situation is constant. He has many comorbidities, advanced cancer, stage 4, with many. This is very obvious that the patient couldn't make it. That's why they will see. By the way, in the hospital, for example, if the patient, you start to do CPR for a patient, and this patient is unlikely to be successful, and he has many comorbidities, the ICU team will revise the case, and they found no, they wouldn't accept the patient after the CPR. And what's your solution at that time? So it's difficult decision, because even you decided to do that, and this is unlikely to be accepted by ICU. This is like you did something without any gain. Okay, but so it's better if you feel yourself you can't convince the patient, try your best to say this is, for example, just look at the scenario. This patient is for DNR. Try to convince the patient about DNR. Do your best in very firm, empathetic way that this is unlikely to be successful. So we usually, when we try to commit any or to do any kind of treatment, we are usually doing we're weighing if the benefits and the bad effects of it. When the benefit is more than that, we'll straight away start to do it. If there is no unlikely to be with benefit, unlikely and full of risk, full of it's obvious that is would be unsuccessful. We didn't do harm for the patient. Just to give unnecessarily step of treatment. Okay, that is why we wouldn't do something like that, because we know that it's unlikely to recover. And if there is a chance, as you mentioned to the candidate, and whenever there is that small chance had happened, the quality of life will be very poor. And sometimes the patient would be just connected to machines. There is no life at all. Just only connecting to machines, because the brain will take long time. The patient will recover after long time, and this will affect the brain. So very poor quality of life. And as you mentioned, if the patient didn't accept that, move to another task. Don't try to just push her to accept that. by force. No. Yes, you did your best to explain all the aspects. It wouldn't be successful because your lungs are damaged by this disease, so unlikely to recover, and that is why this decision has been made. And the other things that if you you do this, you will do this for you in the future. This could do for you, mention the risk, mention the complication. And if it's recover in very small chance for that, it would be connected to machines with poor quality of life and with many problems. Okay, that's why. If accept that, okay. Not accept that, okay. Do you what do you think about to take another opinion from our consultant? That's it, and move to other things. That's ABG. Don't waste your time to just try to push the patient to accept your decision. That's all. I don't know if you feel that sensible or no.
Yeah, that makes sense, Doctor. Yeah, thank you, Dr. Darius. Of course. Yeah, try not to be sharp while giving the decision. Try to be convincing one, and at the end, if not accepting, yeah, don't force. You can give an opinion with the consultant or a meeting with consultant and finish the task. It's clear the take-home message from you. It's clear, Dr. Daria. Thank you so much. Thanks all. Any question or any comments? So, no
Dr.
more
Basil?
question. Yes, sure.
Thank you for for bringing this. Actually, so the lasting power of attorney in this case, because it's mentioned in the scenario stem, the lasting power of attorney, right? So that's what, if anyone mentioned it, so that's why we mentioned the other for the patient. No need, if we have something given, we don't need to repeat it, but usually we should ask of them both in this scenario, right? Because based on the algorithm that very about the DNR, that we should ask about them because it will base our decisions. The lasting power of attorney or the advance directive and the DNR decision discussions with the patient.
Yeah, you might be right, because also this patient already son was accepted and he was convinced about DNR. So he might be the one lasting of attorney and he's already knows about the DNR. So yeah, I agree with you on this point. You can add it into the concern of lasting of attorney and advance directive, because the son already was nominated and he was the one knows the decision about DNR and he accepted it, and that's it. The rule now is the opposite, to convince the father or the mother about something the son already approved it. So I agree, yeah, you can do it as one question, lasting power of attorney, along with this advance directive, because it's already signed with the son. But if not, and you will have another task and another time to convince the son, it will be more hard for you to convince the father than to convince the son. But the son already signed it, or he knows it and he accepted it. It's okay. You can nominate him again, or asking the father and the mother about him. Yeah, I agree, Dr. Abdullah. Thank you for this clarification. It's clear. Yeah, thank you. Okay, any other comment? Any question?
So
Okay.
I want the
Yes.
summary actually, that we will continue DNR. The decision is met, right?
Yeah.
So decision is met that we will go for DNR. We will try to convince her with empathy. If she is not agreed, we will try to, diplomatically just maybe deshouldering to the consultant, right?
Yeah, Yeah, exactly.
But
Yes.
DNR decision, because the last, Dr. Dahlia, thank you so much for that page you shared. Here, the last box is written that the patient must be involved in deciding whether or not CPR. So she has the right to know that she's getting the CPR or not. So we have
Yes.
to tell her, but we cannot just force her anymore. But we already decided, but let her know that, yeah, we have decided.
Yeah.
If she is not agreed, we can have an. Okay. Thank you, Dr.
Yeah.
Dahlia.
We can't ignore her and we can't force her. Yes, both of them. Yes. So she will share with us the decision. As the autonomy, this is the autonomy definition, to know and to share and decide. So she will know in this meeting and she will share, and the decision by us, but she will share the decision with us. Okay. Thank you, Dr. Tanya, for the summary. And thank you for bringing fresh cases from exam direct to us. If you have another case, you can also present in the coming days. We
Yeah,
can end
inshallah.
the,
I have planned to do
yeah,
the new cases so that
yeah,
I feel like with discussion we learn more, right?
yeah, brainstorming one. Yes, you're right. Yeah, yeah. Thank you so much, Dr. Dania. I can end now the recording, then we can nominate for tomorrow session. Okay.
I'm sorry, guys, but
Yeah.
in the algorithm, they say if decision is not accepted by the patient, a second opinion. A second opinion
Yeah.
from whom?
From another meeting with consultant.
A consultant. Okay.
Yeah. Okay. Thank you, Dr. Abdullah.